Hello, this is Dr. Tami DenOtter. Today's mini lecture will be on acute fractures of the proximal femur and the radiographic workup of acute hip pain. Let's get started. Our first radiograph is a frontal radiograph of the left hip in a patient with acute left hip pain. What do you see? Great. Hopefully most of you can appreciate that there's a sclerotic line involving the subcapital region of the left femoral neck. We also have an acute angle along the medial aspect of the femoral head-neck junction, which is a sign of an acute fracture. If we look at this radiograph, hopefully most of us can appreciate that the femur is held in flexion and slight external rotation. This is due to an unopposed iliopsoas, and this makes the lesser trochanter more prominent. This is commonly the position the hip is held in when there's an acute hip fracture. So again, on this radiograph, we see prominence of the lesser trochanter with external rotation of the hip. We see a line of linear sclerosis involving the subcapital region of the left femoral neck, and we see an acute margin along the femoral head-neck junction, which can be a sign of an acute hip fracture. Our next radiograph is also a frontal or AP radiograph of the left hip in a patient with acute left hip pain. What do you see? So we also see an acute fracture of the subcapital region of the left femoral neck on this radiograph. Here, the lateral margin of the femoral head/neck junction has an acute angle, and we see a sclerotic line or fracture involving the subcapital region of the left femoral neck. When evaluating hip fractures, we can use Shetland's line, which is a imaginary line that courses along the medial aspect of the femoral neck to the inferior margin of the superior pubic ramus. We want to make sure that this line stays forms a nice circle, or otherwise we have suspicion that there's a possible impacted fracture or something wrong with the femoral neck. Here is a coronal T1 image, MR image of the pelvis in a patient with an acute left femoral neck fracture. Here we can appreciate partial visualization of the fracture with marks surrounding bone marrow edema. We have a corresponding coronal fluid sensitive MR image of the same patient. Here we can better appreciate the fracture line involving the femoral neck and the surrounding bone marrow edema. Fractures of the femoral neck, actually fractures of the proximal femur, can be subdivided into femoral neck fractures, intratrochanteric fractures, and subtrochanteric fractures. Femoral neck fractures can be further subdivided into subcapital, which is what we've already seen, transcervical, so throughout the mid portion of the femoral neck, and basicervical, which is along the very base of the femoral neck adjacent to the trochanteric region. Subcapital and transcervical fractures are intercapsular fractures. There is disagreement in the literature if basicervical fractures are true intercapsular or extracapsular fractures, but they are usually treated as extracapsular fractures. So here is a frontal radiograph of the left hip. And again, a patient with acute hip pain. What do you see? Good. Hopefully most of you can appreciate that there's a very subtle area of lucency involving the basicervical region of the left femoral neck. So this is an acute basicervical fracture of the left femoral neck. Fractures of the femur can be very subtle, as in this case, or they can be very obvious if there's any displacement or angulation. Anytime we evaluate a femoral neck fracture, or any fracture for that matter, we need to appreciate if there's any underlying abnormality of the bone, which would make this a pathologic fracture. This is not a pathologic fracture. This is just an acute fracture that occurred through normal bone. Now we're moving on to an AP radiograph of the pelvis. Again, this patient has acute hip pain is the history we are provided. This radiograph is to remind us that we need proper imaging and the best clinical history we can appreciate. If we only get pain, it's a lot of times hard for us to give the best radiographic report. And this is a poor radiograph on how it's imaged. We poorly visualize the left hip on this radiograph. We always want to have the smallest field of view possible to better visualize any abnormality. So here is a much better imaged radiograph of the left hip in the same patient. And here we can clearly see that there's an acute fracture. This fracture here is an acute intratrochanteric fracture where we see breach of the lateral cortex of the greater trochanter, and we see partial visualization of the intratrochanteric component of the fracture. Again, this fracture is an extracapsular fracture because it is an intratrochanteric hip fracture. This is the corresponding CT in the same patient. Here we again see the fracture coming through here, and we see cortical disruption laterally, and we see cortical disruption medially. Again, we have a frontal or AP radiograph of the left hip in a patient with acute left hip pain. What do you see? Well, on this radiograph, I do not see a fracture. Let's remember that femoral neck fractures can be occult. Approximately 7% of femoral neck fractures are occult. We've previously discussed occult fractures in our prior mini lectures. The first line of radiographic workup in a patient with acute hip pain is radiographic imaging. If there's high clinical concern for an occult fracture in a patient with trauma, then MR imaging is considered the second line modality for the detection of acute hip fractures, and it should be obtained within 24 hours if that is available. If MR is not available, then CT imaging is considered the third line. Here is that same patient, and this is a coronal T1 image, and this is a coronal T2 image showing that there's an acute fracture. Next, here we're showing that this is a basicervical fracture through the femoral neck, right here, as well as there's subtrochanteric extension of the fracture line. So we have basically a basicervical fracture going into the intratrochanteric with subtrochanteric extension of the fracture. Okay, next we have an AP radiograph of the left hip again in a patient with left hip pain. What do you see? Great. Hopefully most of you see that there is a questionable bone lesion here. We're actually starting to lose the cortex over here, and I see an area of increased sclerosis. This radiograph is to remind us that not all acute hip pain is due to fractures. You can have bone lesions or other abnormalities. Here's the corresponding CT of the same patient after I suggested that I thought there was a concern for a bone lesion. We do see a bone lesion right here through that within the left intratrochanteric region. We also see some thinning of the cortex laterally. This patient went on to get a PET scan, and here we see abnormal tracer uptake corresponding to the bone lesion. So this unfortunately was secondary to osseous metastases. So please remember that we need to evaluate the hip for acute fractures as well as any underlying pathologic fracture or just bone lesion that can have the patient presenting with acute hip pain. I hope you enjoyed your mini lecture on hip fractures and the workup of acute left hip pain or acute pain. Thank you.